So in GIT pharmacology, we will cover following topics. First, we'll start with the mouth. That is, there are some drugs which act at this level. It means there are some drugs, they will act as the salivary glands. They may enhance the salivary secretion or they may block the salivary secretions. Then, after mouth, we'll go to the stomach. We'll go to the stomach. In case of stomach, we have some drug. They may increase the gastric secretion or they may decrease the gastric secretion. In case of mouth, there are two categories of drug. One which increase the saliva and one which decrease the saliva. And at the level of stomach, some increase the gastric secretion or some drug they may decrease the gastric secretion. Then another category which act at this level, they are prokinetic. There are some prokinetic, it means they increase the motility. They increase the motility. So in this video we will cover three topics. First, the drug acting at mouth, they may increase your saliva or they may decrease your saliva. Second is drugs acting at stomach. So at the level of stomach, they may increase the gastric secretion or there are some drugs which decrease the secretions. And the third at the level of stomach or your small intestine, we have prokinetics. These prokinetics, they will increase the GIT motility. So in this way, we'll cover salivary gland, agonist, antagonist, then secretion agonist, antagonist, and some prokinetic drug. So the first category in GI pharmacology will start with the mouth. So in case of mouth, we have salivary glands. They are responsible to produce saliva. So there are drugs which increase the saliva or there are drugs which decrease the saliva. Those drugs which increase the saliva, they are called sialogogues. They are called sialogogues or simply sialics. They may be direct acting or they may be indirect acting. Direct means they will stimulate M3 receptors. They will stimulate M3 receptor. And there are indirect. Indirect means they will stimulate your taste bud. So this drug will act at your taste bud. Then there are some drugs which decrease your saliva. That is your atropine. And second is we have glycopyrrolate. Glycopyrrolate. So saliva secretion may be increase or may be decrease. Those drugs which increase, they are sialogogues or they are sialics. Then they may increase this by direct action. These directly stimulate M3 receptor. The example is carbachol. Carbachol. And indirect actings, they stimulate the taste bud. It means those things which stimulate your taste bud, they must be bitter in taste. So these drugs are also called bitters because things which are bitter, they will stimulate the taste bud and indirectly increase the saliva. So in this class, there may be direct acting through the M3 receptor, carbachol, and indirectly there are some bitters in stimulate the taste bud. One best example is your strychnine. Strychnine molecule, that is Nux vomica, it is not only a spinal cord stimulant or not only a convulsant drug, but the taste of this molecule, strychnine, it is bitter. So it will stimulate the taste bud, indirect action, and that will increase the saliva. Then the other category, your atropine and glycopyrrolate. These drugs will decrease the secretions. Atropine and glycopyrrolate. We have two, atropine and glycopyrrolate. What is the difference between these two? This drug will cross your CNS blood-brain barrier, but glycopyrrolate will not cross the blood-brain barrier. Second thing, atropine is destroyed by rat, cat, and rabbit. These three species, they have enzyme called esterase. That esterase will destroy the atropine, so this drug is not effective in these species, your rat, cat, and rabbit. So in these species, we can use glycopyrrolate. One more difference with these two drugs is your ruminants. In case of ruminant, if we use atropine, it will make the saliva viscous. It will make the saliva viscous. The mechanism is unknown, but still they say that viscous saliva will be formed if we use atropine. So in case of ruminant, atropine will lead to viscous saliva. So atropine is not used, not recommended in case of your ruminant. So glycopyrrolate also decrease the salivary secretion, but the good thing is it will not cross blood-brain barrier. Therefore, no central side effects. No central side effect. But the atropine crosses the blood-brain barrier, so it will lead to some CNS side effects also. So these were your drugs which stimulate the saliva or which may inhibit the saliva. Next, if we come to the stomach, then what is inside the stomach? We have gastric juice. So that gastric secretion may be increased or it may be decreased by some kind of drugs. So what are the things which increase? So there are three molecules, they will increase the secretion. First we call histamine. Histamine increases gastric secretion. And the second molecule, that is your gastrin analog. If you use the gastrin hormone analog, it also increases the secretions. And the more important category, stomachics. These are the drugs, they increase your gastric secretions. And these may be your M receptor or your neostigmine. These may be some bitters and this may be sodium bicarb. Then there are some gastric acid or gastric secretion decreasing drug. They are H2 blockers. We call ranitidine, famotidine, cimetidine like group. Second, we have proton pump inhibitor, proton pump, pantoprazole, omeprazole type of drug. Then we have M1 blocker, pyrenzipine and tilenzipine. And the last we have prostaglandin E analog, that is your misoprostol. Misoprostol. So this category of drug they decrease the secretion. So starting with the first H2 blocker. So in case of stomach, we have a cell that is called parietal cell. Parietal cell. And this cell is having many receptors. That may be your H2 receptor. And at this site, it is having proton pump. And it is also having some M receptor. So if we block this H2 receptor, or if we block M1 receptor, or if we block proton pump directly, in all the three cases, we can decrease HCl production. We can decrease HCl production. So the first category, H2 blockers, will start with our first drug, cimetidine. This was the first H2 blocker drug. But and also it was known as prototype drug, the first member, cimetidine. But because of some side effects or least potency, it is not used nowadays. So your H2 blocker, cimetidine, has following limitations. It is an inhibitor of CYP450, means enzyme inhibitor. Second thing, it is anti-androgenic. It means it will cause gynecomastia. Gynecomastia. It will lead to decrease in libido. Decrease the libido. So these are some of the bad effects related with this. And one more thing, it also increases prolactin prolactin level. And one more thing, it also inhibit tubular secretion in glomerulus nephron. It inhibit tubular secretion of procainamide, drug procainamide. So these are the following limitations so that we stopped using this drug because it is an enzyme inhibitor, anti-androgenic, which cause gynecomastia, decrease the male libido, increase prolactin level, and inhibit tubular secretion of your drug procainamide. So because of this, it was now it is not in use. The next drug is your proton pump inhibitor. It means at the parietal cell we have a pump and the name is H plus K plus ATPase. This pump is proton potassium. So all the words are P for proton, P for potassium, ATPase. So this is proton pump. So this proton pump, that is H plus K plus, will secrete HCl. So we have drug to block this pump, like the prototype is omeprazole. It was the first drug, prototype drug. This drug is also known as drug of choice for ZES. What is this? Zollinger Ellison syndrome. This is nothing but a tumor of G cells of the stomach. When there is a tumor, there will be more secretion of the acid and more stimulation of the proton pump. So we use omeprazole. Zollinger-Ellison syndrome. We use the drug of choice called omeprazole. These drugs Proton pump inhibitor. One more important MCQ related with proton pump inhibitor is they are they are also known as hit and run drugs. Hit and run drugs. They are irreversible. They are irreversible inhibitor of proton pump. It means if they block the proton pump, then it will become non-functional. The body has to synthesize a new pump. Body has to synthesize a new pump. So this mechanism is irreversible. Once they bind and block, there will not be functioning. After some time, body will synthesize a new pump. So irreversible inhibitor of the proton pump. They hit the proton pump and they run, that is, after some time they will come out of the body through the urine. So they run out the body and that hit was irreversible. That is permanent damage to our proton pump. So body has to synthesize a new pump. So these points are related with your proton pump inhibitors. And these proton pump inhibitors are acid labile. They are acid labile. So these are formulated as enteric coated tablets. These proton pumps, they they are outside coated with some material. We call them enteric coating. Why enteric coating is necessary? To prevent it from the HCl of stomach. Because if we use a proton pump directly into the stomach, then that stomach acid will destroy our drug. So what we do, we make a coating and send into the body. That coating will dissolve in the intestine, and from the intestine the drug will absorb, come into blood, then from the blood it will come into stomach at the site of parietal cell. So this is how the drug move. So drug is acid labile, come into stomach, we have coated it with enteric coating, then come into the alkaline pH, coating dissolve, it enter into blood absorption, then from the blood enter into parietal cell. Then it will cause permanent damage, that is irreversible inhibition. That's why these drugs are also called hit and run drugs. So at the parietal cell, we are done with H2 blocker because there was receptor histamine. Then there was M receptor and there was proton pump. So we are done with proton pump inhibitor and H2 blocker like your cimetidine and your ranitidine. Now we are dealing with M receptor blocker. There are two drugs, pyrenzepine and your telenzepine. These two drugs they inhibit the M1 receptor, so there will not be any signal inside and no HCl production. They decrease the secretion. That is simple cholinergic anticholinergic mechanism. Then one more is related with the prostaglandins. Prostaglandin E. These prostaglandins, their role is to provide a coating, mucus plus bicarbonate coating to the stomach mucosa. And the second function of this PGE2 at the level of parietal cell, they will inhibit HCl secretion. So if we use a drug which is similar to this, our prostaglandin E, exactly similar in structure, so we call them analog. So if we use an analog that is structurally similar, that will also come inside the body and inhibit HCl secretion. So we use analog, that is your misoprostol, that will come and inhibit HCl secretion. Then there is one more category of drug, and that are called antacid. Antacid, they do not work at your parietal cell. They just neutralize the preformed acid. So there are two category. One is magnesium salt and one is aluminum salt. But the problem with these two is this is your laxative or purgative, but this aluminum is constipating effect. It causes constipation. So what we do, we combine both laxative effect as well as constipation effect, so that because of this combination there will be less effect on motility of our GIT, because we do not want we don't want to disturb the motility. We just want to neutralize the HCl. We want to neutralize the HCl. So we do not want constipation effect. We don't want this laxative effect. So what we do, we combine both the molecules in the same combination, so that there is less or minimum effect on the motility. So these antacid, they do not have any effect on the motility, but they have effect on the HCl. They will neutralize it. Then the next thing, if we continue to use this antacid, if we continue using this antacid, then suppose there was HCl and we gave our antacid. This antacid neutralizes all the acid, then this antacid increases the pH. Increases the pH. That increased pH is taken as a reflex by our body, and in as reflexly the body will secrete gastrin, and that gastrin again act on the parietal cell and again lead to HCl production. So in this way, antacid was given to neutralize the acid, but because of excess alkalinity, pH increases and body take is at a as reflexly body respond it by secreting gastrin, and because of excess gastrin secretion, there will be more HCl secretion. So because of this reflex, the end result is excess of acid, and this excess of acid is known as acid rebound. This is called acid rebound condition. This is called acid rebound condition. Acid rebound condition is a reflex gastrin release. So there are two things with the antacid. One is combination is given, like aluminium magnesium salt, and another is your uh, acid rebound condition, where there is reflex gastrin hormone will be released and that act on parietal cell that may lead to excess acid secretion. Then we have one more category of drug that is known as cytoprotective. Cytoprotective. Suppose in the stomach there is an ulcer. This is the ulcer. If HCl is there in the stomach, that HCl will keep on irritating the ulcer. So we want to protect, they are protective. We want to protect this ulcer from acid attack. So to protect this ulcer, we use some molecule. To protect this ulcer, we give a drug sucralfate. We give a drug sucralfate. The good thing about the sucralfate is it is a monomer. It is a monomer. When the pH is less than 4, it will polymerize. It will polymerize. So this is the ulcer site and our sucralfate molecule reach to this site and at this site it will polymerize like this. It will polymerize. It will polymerize and cover the ulcer. So now acid will not be able to attack the ulcer and it will get enough time to heal. It will get enough time to heal. So this covering of sucralfate is also known as your stomach band-aid. Stomach bandage. Similar to the, if we have any wound area, we apply some bandage. In case of stomach ulcer, we apply this molecule. It will polymerize and form a bandage. So we call it stomach band-aid. So your sucralfate is your stomach band-aid. Where monomers are there, they polymerize and they cover the ulcer and protect from the acid attack. So this is the mechanism of sucralfate. Then there is one more drug similar to this, just to remember the name. That is CBS, colloid bismuth subcitrate. Subcitrate. So these were two cytoprotective drug. Okay, one more important thing with your sucralfate. Uh, never use, never use sucralfate with antacid. Antacid. Because sucralfate need pH less than 4 to polymerize, and antacid they will increase the pH. So in that pH, our sucralfate will remain as a monomer. It will not polymerize and it will not be effective. So never use your sucralfate with antacid. One more information. Then there is one more class of drug that is called prokinetic. We call them prokinetic. Kinetic means movement. Kinetic means movement. And movement in GIT we call motility. So these drugs they increase the motility. The first class of drug is your D2 blocker. D2 antagonist. There are two members in this category. One is metoclopramide and second is your domperidone. Metoclopramide is not only prokinetic, it is also anti-emetic. So there are two properties it is carrying. Then this domperidone is only your D2 blocker. But this molecule, metoclopramide, it acts via three receptor. It block D2, then 5-HT3, then 5-HT4. So at 5-HT4, sorry, 3, it inhibit or block, and but 5-HT4 it will stimulate. So these via three receptor it work, but the main action is via your D2. Then one more important information for these two is blood-brain barrier. Your metoclopramide drug, it crosses the blood-brain barrier. Then it will lead to some CNS side effect. CNS side effect. And these side effects are known as extrapyramidal extrapyramidal side effect. But domperidone does not cross blood-brain barrier. So no CNS side effect are seen. No side effect are seen. And one more information about the metoclopramide is metoclopramide does not act as a prokinetic at the level of colon. It means colon motility colon motility is not increased enhanced by your drug metoclopramide. It will act at the upper small intestine. It will act at the small intestine but will not act at the level of colon. So no motility enhancement occur. It will not enhance motility of colon. It is very important to remember. Then there are other drugs which increase the motility. One is 5-HT4 agonist. That is your cisapride. That is your cisapride. What is the use of this drug? Is that use is very important. Feline megacolon. In case of feline megacolon, there is hypomotility. There is hypomotility of colon. So we give cisapride. In case of cat, there is megacolon. Because of that, there is hypomotility. We use the drug cisapride, which is nothing but your 5-HT4 agonist. Then the next category is your motilin receptor agonist. That is nothing but your antibiotic. We call it erythromycin. So erythromycin is an antibiotic which is having prokinetic action. How it produces that action? At the level of GIT, this is the GIT cell, there are some receptor, we call them motilin receptor. So in case of cat, this drug will stimulate motilin receptor and cause prokinetic effect. But in case of dog, that is not through the motilin receptor, that is through some cholinergic, that is through some cholinergic and neurokinin activation. So this is how in both the cases your erythromycin will act as a prokinetic, increase the motility, but in case of cat it will act as motilin receptor and increase the activity. But in case of dog, indirect action is there. Act through the cholinergic as well as neurokinin receptor activation. So if I summarize all these things, so what we have covered, one is drug acting on our saliva. Some drugs increasing, some was decreasing. Second, we move to stomach. That was our gastric secretion. Some drug increases secretion and some drug decreases. Third category was our antacid and the fourth was our prokinetic. In case of prokinetic, we covered D2 blocker, then 5-HT4 agonist, then motilin receptor agonist. So for this video, these topics were selected. Your salivary secretion that may increase or decrease, gastric secretions that may increase, decrease, and that decrease was by H2 blocker, your proton pump, your M1 blocker, and your analog of prostaglandin E. This much. Antacid, aluminum magnesium salt, prokinetic, D2 metoclopramide domperidone, here cisapride, and here we did erythromycin. So these were some important topics regarding the GIT.